Dear Chair, dear audience, let me present my PhD work with the title Evaluation of Oncology Treatment Approaches and Clinician Practices for Safety, Efficacy, and Adherence. My name is Anita Pfeffer. I'm a medical doctor and a PhD student at the Pediatric Center Semmelweis University. My vision is to improve the survival and life quality of oncological patients. In order to achieve this, my mission is to identify the least harmful and most effective therapeutical opportunities for oncological patients. Here you can see my two ongoing projects. In my first project, I investigate the effectiveness and safety of available therapies in adrenocortical carcinoma, and in my second project, I focus on the efficacy and safety of growth hormone therapy for pediatric brain tumor survivors. Let me tell you some details about my first project with the title Investigating the Effectiveness and Safety of Available Therapies in Adrenocortical Carcinoma. We are working on a systematic review and meta-analysis in this topic. Adrenocortical carcinoma is a rare malignancy with poor prognosis. Regarding the treatment protocol, a uniform guideline is not available. That's why the reason is to investigate the effectiveness and safety of additional therapeutical modalities in this disease. As you can see, the gold standard therapy in all stages is surgery, but from stage 2, we can choose between different adjuvant therapeutical modalities. But there is a lack of knowledge whether each adjuvant therapeutical modality contributes to recurrence-free survival and overall survival. My clinical question is, which adjuvant therapeutic modality provides the best survival and lowest number of side effects? We used the PICO framework. We investigated patients with adrenocortical carcinoma and compared mortality and side effects between those who received additional adjuvant therapy to those who did not receive it. My hypothesis is that all types of additional adjuvant therapies lead to higher risk of developing side effects, but increased survival rate in adrenocortical carcinoma. We conducted our systematic search in the middle of November 2023, and we updated it in the middle of November 2024. We found more than 19,000 hits, and after the whole selection process, we had 86 eligible full text for analysis. Let me show you my most important results. On the first forest plot, we investigated the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without mitotan treatment. Hazard ratio is a measure used in survival analysis to quantify the relative risk of an event occurring in one group compared to another over time. It represents the ratio of the hazard rates between the two groups. We included 50 retrospective cohort studies in our analysis, and we divided them into 3 different subgroups based on the stage of the disease. We investigated separately the overall survival in patients with stage 1-4, in patients with stage 1-3, and in patients with stage 4 disease. The importance of this subgroup analysis is that the effectiveness of the treatment can be highly influenced by the extent of the disease. The measure of effect was adjusted hazard ratio. If the hazard ratio is more than 1, so it is on the right side of the level of no effect, it indicates that the intervention group has higher risk for death compared to the control group. If the hazard ratio is less than 1, so it is on the left side of the level of no effect, it indicates that the intervention, so in that case, additional mitotan treatment reduces the risk of mortality. The overall hazard ratio is 0.54, which shows that additional mitotan treatment reduces the risk of death by 46%. This result is clinically relevant and statistically significant. We got similar results based on our subgroup analysis, and we found that additional mitotan treatment significantly reduces the risk of death in patients with stage 1-4 and in patients with stage 1-3 disease. On the second forest plot, we examined the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without additional radiotherapy. The overall hazard ratio is 0.66, which shows that additional radiotherapy reduces the risk of death by 34%. This result is clinically relevant, but not statistically significant. However, we found that additional radiotherapy significantly reduces the risk of death in patients with localized adrenocortical carcinoma. On the third forest plot, we examined the effect of cytotoxic chemotherapy on overall survival in this patient population. The overall hazard ratio is 0.61, which shows that cytotoxic chemotherapy seems to reduce the risk of death. However, there is a wide confidence interval caused by the third outlier study, which must be taken into consideration when discussing this result. The most important strengths of our analysis are the stage-based subgroup analysis, the high number of participants, and the complex and comprehensive analysis. To highlight limitations, most of the included studies are non-randomized studies, there is a high heterogeneity of patients' characteristics, and there is missing adjustment for important variables in some studies. In conclusion, we can state that mitotan treatment and radiotherapy prolong survival in both localized and advanced stages of adrenocortical carcinoma. The clinical implication of our finding is that both mitotan and radiotherapy improve oncological outcomes, so the routine use should be considered in the clinical practice. Further research is needed to evaluate the efficacy of cytotoxic chemotherapy, analyze the effectiveness of the different treatment approaches across different stages and among pediatric patients, and more RCTs are needed to minimize the selection bias. Firstly, we submitted our manuscript to the Lancet Oncology at the end of September 2024. After 3 rejections, we decided to submit our paper to the Journal of Clinical Endocrinology and Metabolism at the end of March 2025. After a review, they sent it back for a revision, and now we are working on a revised version of our manuscript. Let me tell you some details about my second project with the title Efficacy and Safety of Growth Hormone Therapy for Pediatric Brain Tumor Survivors based on real-world data. We are planning to do an international survey in this topic. Brain tumors are the most common solid pediatric malignancies. Thanks to the improvement of the treatment opportunities, the 5-year overall survival rate is over 80% in these patients. However, as a result of oncological treatments, we often have to reckon with serious endocrine side effects. One of the most common is growth hormone deficiency, which can be caused by the hypothalamic pituitary dysfunction from the tumor itself, surgical resection, or radiotherapy as well. Now, there are well-developed guidelines for initiation and use of growth hormone replacement. Despite this, several studies show that in clinical practice, the treatment of the affected patients, considering some important aspects, is not carried out in accordance with the current guidelines. That's the reason why my aim is to evaluate the management of growth hormone deficiency in the clinical practice and investigate the effect of the different treatment approaches for safety and efficacy. My clinical question is, how does the different management of growth hormone replacement influence the growth and the risk of recurrences and secondary malignancies in pediatric brain tumor survivors? I would like to use the PICO framework in which population will be pediatric brain tumor survivors, intervention and comparison the different management of growth hormone replacement, the primary outcomes, recurrent disease and secondary malignancy, and the secondary outcomes, shortfall of height and catch-up growth. My hypothesis is that management of growth hormone replacement, according to the international guidelines, provides the best catch-up growth and lowest rate of recurrent tumors and secondary malignancies. Here you can see the progress of my first project. We prepared the planned questionnaire, database, and protocol, and we updated them based on the suggestions of external experts in this topic. Now we are waiting for the ethical approval of our project. To summarize, as I mentioned earlier, my most important aim is to improve the survival and life quality of oncological patients by identifying the least harmful and most effective therapeutical opportunities for them. With these 2 researches, I would like to contribute to achieving this. I consider it extremely important to collaborate with younger researchers and to support their scientific activity. I would like to say thank you to my TDK student whose work has contributed to both of my projects. I would like to finish my presentation with the words of Albert Szent-Györgyi, who said that research is to see what everybody else has seen and to think what nobody else has thought. Thank you for your kind attention.
A second question to the irradiation. Were there any information on predisposition syndromes, and do we have to take this into account with respect to induction of secondary malignancies, for example, when irradiating these patients with adrenocortical carcinoma?
Sorry, could you repeat the question?
Whether there are any predisposition syndromes underlying that maybe influence the choosing irradiation or not for the patients, whether there were informations in those studies on this?
It's extremely important in case in those studies which investigated pediatric patients. So, for example, in these cases, they avoid using radiation therapy, but the other studies which we included could not observe patients with cancer predisposition syndromes or something like that.
Okay, thank you. And then I would like to ask you also questions on the second project. There are different factors contributing to growth hormone deficiency in pediatric CNS tumors. So do you account for those, or is it a cohort that is selected only for post-therapeutic changes?
We would like to include patients with different types of tumors, different localizations of the tumors, and we would like to make subgroup analysis based on the different therapeutical approaches or different surgical techniques, radiation therapies which they got. So we would like to handle these groups separately.
Do you have access to the irradiation plans for this?
Yes, we collaborate with those colleagues who made these therapies. So yes, we will have data about it.
And the second question would account for, so there's not only growth hormone, but also other hormones of the pituitary that may be influenced post-therapeutically or by the tumor. Do we account for this? For example, for pseudo pubertas precox or true pubertas precox or hypogonadotrism?
Yes, we would like to check the appearance of these other endocrine symptoms, so the whole spectrum of hypothyroidism, so yes.
Excellent. Any other questions?
Could you go back to your first figure? It's about the overall survival. I'm just wondering if the follow-up time is approximately the same or it varies among the studies, because the follow-up time is not given here on the figure. Can you recall these time frames?
Yes, thank you for your question. Not all of the studies reported the exact follow-up times. So there is a heterogeneity in it between the studies. Most of the studies told us information about 3 or 5 years follow-up time. So most of the data are based on this, but not in all of the cases.
If it's given, it's usually between 3 and 5 years.
Yes, in most of the cases.
Thank you for your presentation. I have a similar question as before. You have adjusted hazard ratio, so I would like to ask what are they adjusted for, and are these adjustments the same for all studies?
Thank you for your question. Most of the studies adjusted for a lot of parameters. Almost all of the studies adjusted for the age of the patient, the gender of the patient, the laterality and the size or the stage of the tumor, but there were differences, for example, in the surgical techniques, the surgical margin of the tumor, and so we collected the adjustments or the variables, what were they adjusted in every case, but there were differences between the studies in the adjustments as well.
Well, these differences were clinically relevant, or this is just some limitation that we have?
It's a limitation what we have, yes.
So, and sorry, one more question. I see that your subgroup is like stage 1 to 4 and 1 to 3. It is because the studies included patients for all stages and they didn't give separate.
Yes, so basically our aim was to investigate the effect all of the treatments separately in all of the stages, but it's a very, very rare condition. So most of the studies provide information just including all of the stages, or for example, they made a subgroup analysis based on localized or advanced disease, so differences between stage 1, 3 or stage 4, and that was the best option what we could do to handle this. So we need more studies in this very rare condition.
Yeah, thank you for your
Thank you very much.
Congratulations for your presentation. I'm just curious, How frequently do you need to monitor the blood mitotan levels in pediatric patients?
Thank you for your question. Fortunately, we have the opportunity to check this level. It's not available in all of the countries, but we can manage it. Basically, we measure it in every 3 or every 4 months. It depends how regularly the patients come back for checkup.
How long is the inter-treatment period? The time between the cycles is how many weeks?
Thank you for your question. Maybe 1 week, but I'm not sure exactly. It depends.
Then it is not monitored so frequently. If every 2 weeks there is a treatment, right?
Yes. So the reason for always check the serum level of mitotan is, especially, for example, in the case of pediatric population, is that it can cause very serious side effects such as serious hyperemia or neurodevelopmental delay, and that's why we try to always check it, and it's very hard to achieve the normal range of these values. And for example, at our clinic there are just 7 patients with this disease, and we had the opportunity to check their serum levels for 4 of these patients.
And my follow-up question is, what do you think between mitotan and radiotherapy, which provides a better quality of life for these patients?
I think so that radiotherapy provides a better quality of life because it has much less side effects, because mitotan causes, as I mentioned earlier, a lot of serious side effects. Another problem is, for example, hypothyroidism in the case of mitotan, so they need regular checkups to check all of the endocrine, gastrointestinal and neurological side effects.